Hey guys, welcome everyone. I understand because the syncope was a previously scheduled session and then the jaundice was session scheduled for today. So there was a lot of overlap. Apologies for the confusion. We will be addressing syncope as well as seizure in the next or the subsequent session. Okay. So today's session is going to be probably the shortest session from Harrison. We would hardly take 15 to 20 minutes to learn quick points about jaundice. Now, jaundice is definitely one of the common complaints that you would encounter in your patients in the wards, right? Whenever you're taking the case history, jaundice is one of the common complaint. So instead of trying to get deeper into what Harrison says, we will have a crisp and concise approach, purely based on the recommendations from Harrison itself, but a very crisp approach. We will start first by understanding what is jaundice or icterus. Jaundice or icterus refers to give me a thumbs up guys if you're able to hear me loud and clear. Okay, good. So jaundice or icterus refers to yellowish discoloration of the tissues by bile pigments. When I say bile pigments, I am primarily referring to the bilirubin, right? We are referring to bilirubin. Now which tissues are prone to get this bilirubin deposition? Whenever bilirubin level is high, which tissues are likely to get deposited with this pigment? It is mainly the skin, conjunctiva and blood vessels, right? And blood vessels. Why these tissues are prone to get deposited by the bilirubin? Because these tissues have high elastin content, and elastin has a high affinity for bilirubin, right? So these are all relatively tissues with a relative high elastin content, right? Because of high elastin content, bilirubin has affinity for elastin, and thus wherever elastin is more in number, that is where the bilirubin gets deposited. Okay, clear? Okay. Now, when do I say that the serum bilirubin level is increased? What is the normal serum bilirubin level? The normal serum bilirubin level is usually less than 1 milligrams per deciliter, less than 1 milligrams per deciliter. Okay, now from 1 milligram per deciliter, if it becomes 1.1 milligram per deciliter, will I be able to recognize it on clinical grounds? No, right? Only the lab can tell me that it is 1.1. Can I recognize when it is 1.3? Probably no. So when it becomes recognizable? When it becomes recognizable on clinical grounds, like when we examine for the jaundice. So it becomes clinically recognizable when serum bilirubin level is more than greater than 2 to 2.5 milligrams per deciliter. 2 to 2.5 milligrams per deciliter. Most of us will be able to identify that, okay, this person's skin or the conjunctiva is looking yellowish when it is 2.5 milligrams per deciliter or higher. Some older books mention 1.5, but when objective studies were done, like asking the experienced clinician to identify whether this patient has jaundice or not, most of us were not able to recognize until and unless the bilirubin level was past 2.5 milligrams per deciliter. Okay. So what is jaundice? Yellowish discoloration because of deposition of bilirubin. It becomes clinically recognizable when the serum bilirubin level is more than 2.5 milligrams per deciliter. Now what are the sites where we will be looking for the icterus or jaundice? What is the most preferred or the most common site? The preferred or the most common site. One of the commonly asked bedside discussion question. Where do you look for jaundice? Right? What is the preferred site? Obviously we look into the eyes, right? But a common mistake that most of the students do is tell sclera, right? It is not the sclera. Sclera generally does not get good deposition of the bilirubin. It is still the conjunctiva. Old school thought, right? Decades back we used to say that jaundice will look for the sclera and pallor will look for the conjunctiva. Today's understanding is the yellowish discoloration of the eyes that we see is also because of the deposition of bilirubin in the conjunctiva and not in the sclera. Scleral icterus is a misnomer, right? Please write it down. Scleral icterus is a misnomer. So what should be our answer? Conjunctiva. Which conjunctiva? the bulbar conjunctiva, right? Not the palpebral conjunctiva, bulbar conjunctiva. Lower palpebral conjunctiva is what we are looking for when we have to look for pallor. For icterus, we look at the bulbar conjunctiva. To be more precise, the upper bulbar conjunctiva. Upper bulbar conjunctiva. That is the most preferred and the most common site to look for jaundice. Okay. Apart from that, you can also look at the palate, dorsal surface of the tongue, palms and soles, and the general skin. Right. So these are the sites for examination of the palate, examination of the icterus. One important prerequisite whenever someone asks you to examine whether patient has got icterus or not is to make sure that you examine in daylight, right? Under artificial lighting, particularly fluorescent lighting, even normal white tone can appear slightly yellowish, and that can create confusion. Similarly, under bluish lighting, it may be difficult for us to appreciate even when there is jaundice. So under under the fluorescent yellowish light, even normal conjunctiva might look like jaundice. Under bluish light, even the icterus might look like normal, right? So please examine in natural daylight, right? Preferably examine in natural daylight. Okay. So how do I expose the bulbar conjunctiva? By lifting the upper eyelids upwards, right? Generally we examine both the eyes simultaneously. Lift both the upper eyelids upwards to expose the bulbar conjunctiva. You can ask the patient to look downwards and you can appreciate whether it is showing yellowish tint or not, right? Apart from that, you can ask the patient to lift the tongue up and look at the dorsum. You can look into the palate, palms and soles, as well as the general skin. As you see here, this patient has the jaundice of the palms, this patient does not, right? Okay. Now once I have examined and then I have identified that patient has got jaundice, how do I further evaluate, right? So for that, Harrison gives us a very convenient approach. There is an algorithm. So what we will do now is we will spend 5 minutes to simplify this algorithm. So once we have a patient with jaundice, we definitely need to do a good history taking. In the history, we will focus on the onset of jaundice, right? The progression, whether it is associated with abdominal pain and some other potential clues on physical examination, right? But that is not important in the today's context for us to reach to the diagnosis of the cause for jaundice. Ultimately, it is the liver function test which will take us to the cause for jaundice. But 2-3 important points I want you to remember. If we have a patient with jaundice, right, with colicky abdominal pain, what do you suspect? If you have a patient with jaundice and pruritus, along with that you also have pale stools, what do you suspect? What do you suspect? Himanshu, Pranam. If you have a patient with jaundice and colicky abdominal pain, you would probably suspect gallstones, right? You would probably suspect gallstones. If you have a patient with jaundice with itching, pruritus and pale stools, you would probably suspect cholestasis, right? Cholestatic jaundice, or in other words, cholestasis. These are some potential clues, not very important, right? All you need to do is, once you have recognized that patient has got icterus, look into the liver function test reports, labs. Okay. Now in the labs, when you see a liver function test report, you will have multiple parameters mentioned, right? So let me first quickly take you through the liver function test. So when we look at a liver function test report, what all we will get? We will have the readings about the bilirubin levels. So it will have the total bilirubin level, then the direct bilirubin level or the conjugated bilirubin level, and indirect bilirubin level or the unconjugated bilirubin level, right? So this data you will have. Apart from that, you have the values about AST, ALT and GGT, alkaline phosphatase or ALP. What are these? These are all collectively called as liver enzymes. Liver enzymes. And then apart from that, we might also have the total protein, albumin and globulin levels mentioned in the liver function test, right? So all of this comprises what we call as LFT or liver function test. So whenever you have a patient with jaundice, what should I look for in the liver function test? When we see the liver function test report, the first thing you have to see is whether it is only this bilirubin section which is affected, or apart from bilirubin, the other components of the LFT are also abnormal. That is the first and the most important thing. You might have patients where only bilirubin is elevated, maybe direct predominant, indirect predominant, that is secondary, but only bilirubin is elevated. AST, ALT, alkaline phosphatase, GGT, they are all normal. That is one scenario. Second scenario is bilirubin section is also elevated, and this AST, ALT or alk phos, they are also elevated. Right? So these are two separate sets of patients. So we will see how do we proceed once we have looked at the LFT. Right? So in the LFT, if I have isolated elevation of bilirubin, means only bilirubin is elevated. AST, ALT, alk phos, right? Other parameters are normal. Only bilirubin is elevated. How do I approach in that case? If the only bilirubin is elevated, we have to look whether it is the direct predominant hyperbilirubinemia or indirect hyperbilirubinemia. So if I have direct hyperbilirubinemia, what does that mean? From the LFT, the direct bilirubin is more than the 15% of total bilirubin. Whatever is the total bilirubin, out of that, if more than 15% is direct bilirubin, then it is called as direct hyperbilirubinemia. It only means you have two possibilities. Either patient has got Dubin-Johnson syndrome or Rotor syndrome, which are inherited hyperbilirubinemias. Inherited hyperbilirubinemias. And if I have isolated bilirubin elevation, and it is the indirect hyperbilirubinemia, means whatever is the total bilirubin, out of that direct bilirubin is less than 15%. Then it is called as indirect hyperbilirubinemia. Now what are the differentials for this? It can be inherited disorders like Gilbert syndrome and Crigler-Najjar syndrome. Apart from that, hemolytic disorders and drugs like rifampicin and probenecid. Okay. Now how do I approach further in this case? Right? Mainly it is the difficulty to remember. How do I remember Dubin-Johnson and Rotor syndrome as the causes for direct hyperbilirubinemia, and how do I remember Gilbert and Crigler-Najjar as the causes for indirect hyperbilirubinemia? Right? We will make it pretty simple now. I'll give you a mnemonic. Generally, I don't go into mnemonics. I try to concentrate on building concepts, but sometimes mnemonics makes it easier for us to remember, right? So remember direct hyperbilirubinemia, right? So when you say direct, right, let us write direct like this. So when we say direct, in that only we have D and R. Direct, Dubin-Johnson and Rotor. Dubin-Johnson and Rotor. And indirect, drugs is pretty straightforward, right? In the question only they will mention the history that the patient is on probenecid for some indication, or patient is on rifampicin because of the tuberculosis or whatever other causes. So then it is drug-induced hyperbilirubinemia, right? If there are no such history, then inherited hyperbilirubinemias are a possibility. And from the LFT report, if I have noticed that it is indirect hyperbilirubinemia, then Gilbert and Crigler-Najjar are two possibilities. How do I remember that? Just remember a mnemonic CGI. What CGI refers to? Computer generated imagery, right? Nowadays in Bahubali and all those movies, half of the scenes are generated inside a computer, right? So we call it as computer generated imagery. So all you need to remember is that letter. Crigler-Najjar, Gilbert, indirect predominant hyperbilirubinemia. Dubin-Johnson and Rotor, they are direct predominant hyperbilirubinemia. Okay. Then hemolytic disorders are not very difficult to diagnose, because when you have hemolysis, you will also have anemia, right? You will have anemia because your RBCs are being lysed. So that is why it is causing jaundice, but your hemoglobin level would be dropping. So you will have anemia as well as hyperbilirubinemia. Apart from that, depending on the site of hemolysis, you may have splenomegaly and hepatomegaly, right? So that can help you to reach out to the diagnosis. Now on the other side, Prashant Hazari, which is best? Okay, I personally like Cecil, the way the authors have written the content, but the quality of content is good in Harrison. Means Harrison comes out with such algorithms, right? These algorithms are very difficult to frame because we need to go through a lot of studies to come out with these conclusive points. We miss out on a lot of such algorithms in Cecil, but the way it is written, it is very beautifully written. It is a good read. When you want to read, it takes you along with you. Harrison, many a times you need to jump here and there to keep your mind attentive when you're reading Harrison. But in terms of the quality or usefulness of the content, it is still the Harrison, and that is why it has become the gold standard. If I have to give you an analogy, the Harrison is like your Ganong's physiology, concise, to the point, but at the same time, everything is extremely high yield. Cecil is more like Guyton, right? It is more like a beautiful poetry on medicine. But obviously, none of us are in the mood for poetry now. Okay, so we have now looked at the patient with jaundice. We have looked at his LFT. If in the LFT, AST, ALT, ALK phos, GGT was normal, only bilirubin was elevated, we have a very simple approach. We have to see whether it is direct hyperbilirubinemia or indirect hyperbilirubinemia, right? All we have to do is look at the total bilirubin. Let me say total bilirubin is 10 milligrams per deciliter total, and then we have to see how much of that is the direct bilirubin, right? So let me say direct bilirubin is 2.5 milligrams per deciliter. So in that case, this patient has direct hyperbilirubinemia or indirect hyperbilirubinemia. That is one point we need to get it right. See, for your final prof exam, Archit Bolu sir's book is really good. Means if you can replicate what he has written, it is good. I would say that back up it with the conceptual understanding. If the concepts are clear, whatever Archit Bolu sir has written in his book is more than enough for you to get the distinction marks in your final prof. Right, because direct bilirubin is more than 15% of total, right? It is 25% of total. 2.5 out of 10 is 25%. So this becomes direct hyperbilirubinemia. So in that case, we have only two possibilities on this LFT. Either we have Dubin-Johnson or rotor, right? That is our direct Dubin-Johnson or rotor. But if I flip this and change this to, let me say 0.5, in that case, it becomes indirect hyperbilirubinemia. So in terms of inherited disorders, in that case, the possibilities will be Crigler-Najjar and Gilbert. The mnemonic to remember is for indirect CGI, Crigler-Najjar and Gilbert. Okay, but what if I encounter an LFT report in a patient with jaundice where it is not only the bilirubin which is elevated. Apart from the bilirubin, the enzymes, the AST or ALT, GGT or alkaline phosphatase are also elevated. In that case, how do I approach, right? In that case, the approach is going to be pretty simple. What Harrison says is, if bilirubin and other liver tests are also elevated, then we have to categorize it into hepatocellular pattern of liver injury and cholestatic pattern of liver injury. From the history, you might have already suspected the cholestatic pattern when patient is having pruritus, right? And pale stool. You may be thinking that this is cholestatic pattern, but that's not very reliable. The patient's history is also not very reliable, and the assertion of pale stool is also not very reliable. So that is why we are finally relying on the LFT report. Now, how do I identify whether the patient has got hepatocellular pattern or cholestatic pattern? Okay, so this is what Harrison says. We have to look at AST and ALT elevation and the alkaline phosphatase elevation. If AST and ALT are elevated more than the elevation of alkaline phosphatase, then it is called as hepatocellular pattern. And if alkaline phosphatase is elevated more than the elevation of AST, ALT, then it is called as cholestatic pattern. Okay, but it still becomes a bit difficult, right? So what we will do is, we will learn something called as R value. It is not there in the Harrison, but it is nonetheless important for us. R value. What is this R value? We have a formula for it. R value is equal to ALT value of the patient. Let me say we have an LFT where ALT is 120 of the patient. Okay, then alkaline phosphatase of the patient is 220. These are rough numbers that we are talking about. Okay, then upper limit of normal for ALT, let me say that is going to be 40, and upper limit of normal for ALP, let me say that is going to be 110. Now from this we will learn how to calculate this R value. R value is calculated as ALT value of the patient, that is 120, divided by the upper limit of normal for ALT, which is going to be 40 here. This whole thing is divided by ALP value of the patient, which is 220 in this example that we are taking about, and the upper limit of normal is 110, right? So when we decipher this, we'll get the R value. So 120 by 40 becomes 3, 220 by 110 becomes 2, right? 3 by 2 is equal to 1.5. So R value for this hypothetical LFT that we looked at is 1.5. Now how to interpret this R value? If the R value is less than or equal to 2, that means we have cholestasis. R value less than or equal to 2, cholestasis. If R value is more than or equal to 5, that means we have hepatocellular injury. Basically what it means, the liver cells are predominantly damaged. That is why you have the jaundice. In cholestatic, it is not the damage to liver cells. It is the drainage of the bilirubin from the liver into your intestine is what is impaired. Either within the liver or outside the liver, the drainage is affected. That is why we call it as cholestasis. R value less than or equal to 2, we have cholestasis. More than or equal to 5, we have hepatocellular pattern. If it is between 2 to 5, then we say it is mixed injury. Means it can have hepatocellular plus cholestatic component. So when we calculated R value here, it is 1.5. So that means whatever hypothetical number I gave you here has predominantly cholestasis, right? Cholestatic injury pattern. So again summarizing it, R value less than or equal to 2 is cholestatic pattern. R value is more than or equal to 5 is hepatocellular injury. So once we have done that, we have decided whether patient has got hepatocellular injury or cholestatic pattern for jaundice, how to further approach, right? When it is hepatocellular pattern, it is most likely, the most common cause for hepatocellular pattern of jaundice is going to be viral hepatitis, right? So if I have concluded that LFT shows hepatocellular pattern, then I have to do viral hepatitis evaluation, right? We have to do the test for hepatitis A, B, C, D and E. And if it is the other possibilities is paracetamol toxicity can also cause the hepatocellular pattern of injury. And apart from that, certain autoimmune disorders. We don't need to get into the autoimmune disorders for now. Okay. And what if I encounter a cholestatic pattern? That means something is obstructing the flow of bile, right? Either within the liver or outside the liver, something is affecting the flow of bile. So in that case, what should be my next step? Next step is to do an ultrasound. Why ultrasound is useful? Because ultrasound will help me to differentiate whether the obstruction to the flow of bile is within the liver or outside the liver. You know that the biliary radicals or the bile tree drains all the bile and stores in the gallbladder and then eventually gets released into the duodenum, right? This is cystic duct. The common bile duct eventually releases it into the duodenum. Okay. If let me say I have a obstructive stone here, right? There was a gallstone which is dropped into the common bile duct and it is obstructed here. Then there is obstruction to the flow of bile. So bile will all start pouring back into the biliary radicals. From there it will leak into blood and we will have hyperbilirubinemia, right? Obstruction can also happen within the liver to this intrahepatic biliary tree. There can be obstructions. Now how ultrasound will help me further? Ultrasound will help me to identify whether it is intrahepatic biliary cholestasis or whether it is extrahepatic cholestasis. How ultrasound can help? If I have a stone in the extrahepatic part of the biliary tree, right? What will happen to the intrahepatic part of the biliary tree? There is a blockade here, right? So the flow of bile from the intrahepatic biliary tree components to this will be impaired. So all these intrahepatic biliary tree branches will start getting dilated. So whenever we have extrahepatic obstruction, there will be dilatation of intrahepatic biliary radicals. Intrahepatic biliary radicals or the bile ducts. So bile ducts inside the liver will get dilated because there is an obstruction outside. If the obstruction is inside, obviously these intrahepatic biliary radicals will not be dilated. So this dilated intrahepatic biliary radicals can be easily visualized on the ultrasound. And that is why ultrasound becomes the next best step for us. Do the ultrasound and see whether the dilated ducts are there. If the dilated ducts are there, that means the obstruction is outside the liver. We will call that as extrahepatic cholestasis. So it can be gallstones, right? What all can cause the obstruction? A gallstone occluding the CBD can cause. The cancer of the head of the pancreas can cause, right? Then biliary atresia can cause narrow bile duct, right? Or if there is a ascending infection of the the common bile duct called as cholangitis. All of them can cause the obstruction. So for further evaluation, what is the reason for obstruction, we might have to go for a CT or MRI or the MRCP. But ultrasound can help us to differentiate intrahepatic versus extrahepatic cholestasis. So if dilated ducts are there, it is extrahepatic cholestasis. For further diagnosis, we have to go for CT, MRCP or ERCP. And if the ducts are not dilated, that means it is intrahepatic cholestasis. Intrahepatic, right? It is the intrahepatic biliary radicals which are blocked. The common causes for intrahepatic biliary obstruction includes primary biliary cholangitis or primary biliary cirrhosis, PBC, right? The other differential diagnosis includes the chronic hepatitis. That is why we do hepatitis serology and we do this test called as anti-mitochondrial antibody or AMA, right? AMA is the investigation of choice for diagnosis of primary biliary cholangitis, which was previously called as primary biliary cirrhosis. Okay. And if the AMA comes out positive, for final confirmation of the primary biliary cirrhosis, still the gold standard investigation is liver biopsy. Yes, gallbladder cancer causes extrahepatic biliary obstruction, which can be mostly identified on the ultrasound itself and can be definitely confirmed with the MRCP or the ERCP. Okay. Now, if I have encountered a hepatocellular pattern where the R value was more than 5, then if it is an acute case or even a chronic case, I might have to do the viral serology to rule out viral hepatitis. I might have to take the history of exposure to hepatotoxic drugs. If all of these turn out to be negative, then we go for more advanced investigations. The last end result is always the liver biopsy. Harrison says because A, B and C are relatively more common, they are done as first line investigation. D and E are relatively less common, so they are done less frequently. But in India, the most common cause for acute viral hepatitis in adults is hepatitis E. So in India, whenever we do viral hepatitis markers, we do all the markers starting from A, B, C, D, E. So here only we could have got to know whether patient has got viral hepatitis or not. If all the screen is negative, drug history is not suggestive of any hepatocellular injury causing drugs, then final test will be to go for the liver biopsy. The head of the pancreas. The duodenal cancers are like very rare, right? Have you heard of commonly encountering a cancer in the duodenum? Mostly cancers happen when you have a peptic ulcer in the stomach, but duodenal ulcers transforming into malignancy is very, very rare. So if I see a cancer there, it is most likely the cancer originating from the head of the pancreas, which actually causes painless jaundice, right? So this is the approach that Harrison recommends. So giving you a quick summary again, what is jaundice or icterus? Yellowish discoloration of the tissues due to deposition of bilirubin. Bilirubin has an affinity for elastin, that is why it gets deposited in those tissues where the concentration of elastin is high. That includes skin, conjunctiva and the blood vessels. Okay. Normal serum bilirubin is usually less than 1 milligrams per deciliter. When it crosses 2.5 milligrams per deciliter, clinically jaundice becomes apparent. Between 1 to 2.5, only laboratory investigations can identify. Where do we look for jaundice? The preferred site is the upper bulbar conjunctiva, not the sclera. The other sites include palate, dorsum of the tongue, palms, soles and general skin. Okay. Ideally, we should examine in the natural daylight. Fluorescent light or colored light can interfere with our interpretation of yellowish discoloration. Okay. Once we have established that patient has got jaundice, we have to look at the LFT. LFT, we have to see whether it is only bilirubin which is elevated or the other liver enzymes AST, ALT, ALK-Phos, they are also elevated. If it is isolated hyperbilirubinemia, only bilirubin elevated, most likely it will be because of the inherited hyperbilirubinemia disorders like Dubin-Johnson, Roters, Crigler-Najjar or Gilbert. Occasionally it can be because of drugs like rifampicin or probenecid, or occasionally because of hemolytic disorders, right? So in that case, what is our approach? See whether it is direct predominant hyperbilirubinemia or indirect hyperbilirubinemia. Out of the total bilirubin, if more than 15% is direct, we call it as direct bilirubin, hyperbilirubinemia, and then in that case, it is Dubin-Johnson's or Rotor, direct, DR. And if less than 15% of the total bilirubin is direct, that is the conjugated, in that case, drug history needs to be taken and also hemolysis can be considered. And if you're thinking of inherited hyperbilirubinemias in such cases, it is CGI, indirect, because of Crigler-Najjar or Gilbert. And if you encounter a patient where bilirubin and other enzymes are also elevated, calculate the R value. If R value is less than or equal to 2, cholestatic pattern. Do an ultrasound. If ultrasound shows dilated intrahepatic bile ducts, it means the obstruction is outside the liver, extrahepatic cholestasis. So all the causes for extrahepatic cholestasis come into picture. If the intrahepatic bile ducts are not dilated, that means you have intrahepatic cholestasis. One of the common causes for such situation is the primary biliary cholangitis and chronic hepatitis. And in that case, do the hepatitis markers and do the anti-mitochondrial antibody or AMA test for diagnosis of PBC. Okay. And if the R value is more than or equal to 5, you have hepatocellular pattern of liver injury. Most common cause for that is the viral hepatitis. So do all the viral hepatitis markers. Paracetamol is also one of the leading causes, not so common in India, but we should be aware of. So also get the history of paracetamol abuse, right? And if viral hepatitis markers, drugs and Wilson's disease are unlikely to be the possible causes, in such cases for final diagnosis, we might to go for the liver biopsy. This is our approach to any patient with jaundice. So what I would suggest now is that go through this algorithm one more time and then start solving questions on jaundice or hyperbilirubinemia from Meded app or any of the app-based coaching platforms that you are subscribed to. Hopefully you should be able to get more than 50% of the questions on the jaundice right. This algorithm literally takes you to the diagnosis no matter how the question is constructed. Okay. Beyond that, in the subsequent sessions, we will take up some individual causes, and one of the session I'm scheduling is the drug-induced liver injury or DILI, because paracetamol toxicity, other than that, the other drugs which are known to cause liver injury, plenty of MCQs are being asked, and as well as nowadays examiners during bedside discussion also talk a lot about drug-induced liver injury. So we'll have a separate session, and as you requested, the syncope as well as seizures will be addressed soon. Okay, so that's it from me here. There will be 2-3 MCQs on the notes where basically you have to come out with the final diagnosis as the cause for jaundice following this algorithm. Do try that. Okay, so see you on Monday. I think Monday is probably going to be syncope, so we will address it there. Okay, thank you all guys and have a good night. See you soon. Bye-bye. Bye. Bhaumik Bakliwal. Yeah, if the ulcers are not only the duodenum, the kissing ulcer can also be called if it happens in the esophagus or stomach. If they are facing each other and in a collapsed state, if they are likely to approximate, we call it as kissing ulcer. Okay, so the management of jaundice obviously depends on the underlying cause, right? If it is an extrahepatic biliary obstruction, we have to relieve that obstruction. If there is a pancreatic head cancer, we need to get rid of it. If there is a gallbladder stone, that needs to be removed, and maybe stenting of the common bile duct needs to be done, right? So it all depends on the underlying cause. So we will discuss the managements of individual disorders as we take them up. Okay, see you soon guys. Have a good night.